My name's Kim Greaves. I want to make this very informal talk. It's rare that we have the opportunity to have so many practice nurses in one place, so I'd like to draw, this is as much for me as it is for you actually, so I can draw on your experience and opinions on what we should be doing on this journey that we're on at the moment with cardiovascular disease risk scoring. So, sorry, is that better? So, yes, I wanted to thank you for coming, and well done to you who've made it here. This is the last session, I believe, for the day, for the conference. So well done for getting here. So I'm a cardiologist. I've been invited to come and speak about cardiovascular disease risk scoring. And also, if there's time, I'd like to talk about another project that we're doing that will be close to your hearts, I'm sure, too. And so I would like to educate you. The purpose of this is really to educate you about cardiovascular disease risk and then get your opinions on how we can improve uptake in the community. So with that, I shall begin. So the first thing is I've got no conflicts of interest to report. So in terms of the global burden of disease, worldwide there are 60 million deaths per year, and 40 million of these are due to heart disease and stroke, diabetes, cancer, and mental ill health, and 16 million of these were premature. What about Australia? Australia, there are 150 deaths per year, and if I was going to put them in order of amount, stroke would be third, cancer second, and coronary heart disease at top place. But of course, if you combine the two together, coronary heart disease and stroke, cardiovascular disease is way up in front in terms of being the biggest killer in our country. And when I talk about cardiovascular disease, obviously we all know about heart attacks, strokes, peripheral vascular disease, so intermittent claudication, and then there's also renovascular disease, so you mustn't forget about that. What about the economic costs? We talked about the morbidity and mortality. What about the economic costs? Well, Australia spent $162 billion on health in 2015-16, which is about, I think, about 11 or 12, maybe 13% of the total budget that the government has to spend on the country. And of that $162 billion, 19 billion was spent on cardiovascular disease, which is 11% or thereabouts of the health budget. So we're talking big figures here. 19 billion, 11% of the health budget spent on cardiovascular disease. And then let's drill down a bit there. So what are the costs per acute coronary syndrome? What is the cost for each heart attack? $22,000 per hospital admission each time. And over a lifetime, if you look at the loss in productivity, days off, the requirements for extra support, it's about $200,000. For a stroke, it's $27,000 per acute hospital admission, and over a lifetime, it's a little bit less at $117,000. And bearing in mind that you have 88,000 heart attacks and cardiac deaths per year, if you start multiplying up just the acute admissions for about 22,000, I think you come out at around $2 or $3 billion that is spent. Now the important thing about this, so you've got in fact cardiovascular disease is at the top. The majority of these deaths and disease, morbidity associated, is preventable. It's actually preventable. And as we all know, prevention is better than cure. And what is the evidence for this? Well, there's lots of evidence. So I've picked one, an important study in 2004 published in The Lancet called the InterHeart study, entitled The Effect of Potentially Modifiable Risk Factors Associated with Myocardial Infarction in 52 countries. So every continent was represented. It was a case control study, 52 countries. They had 15,150 myocardial infarctions and 14,800 controls. And everybody, the clinical trial staff, they got the patients to fill in questionnaires, they measured biometrics, they had all the data, and they looked at they were able with these numbers to look at the relationship between the risk factors that are related to myocardial infarction and myocardial infarction itself. So they were able to see what are the predictors. And this first table is important because it shows the risk of acute MI associated with these various risk factors in this overall population as a whole. And I've listed them in order of the odds ratio. So there's the likelihood that you are going to have, if a risk factor would predict a certain outcome. So you've got the risk factor here, the odds ratio, that is what are the increased odds if you have this risk factor of having a myocardial infarction, and I've put, for interest's sake, the 95% confidence intervals. So they measured ApoB and APO1, which is basically a representation of cholesterol, elevated cholesterol. And the odds ratio for that, so you are 3 times much more likely to have a heart attack if you had elevated cholesterol. Smoking gave you a 2.9-fold increase. Stress was up there, 2.7, and they measured psychosocial stress as depression, workplace stress, home stress, diabetes, 2.4, hypertension, 1.9-fold increase, obesity, 1.6. And then below, at the bottom, I put the protective factor. So alcohol just squeezed in there, a low to moderate amount squeezed there as being protective. Exercise we all know about, so that's about a 14% risk reduction. And vegetables as well, vegetables and fruit, a 30% reduction. And if you add all the factors up together, so if you had all the adverse effect, if you had all these factors added up together, minus the, I think the alcohol, the protective ones, you had a 129-fold increase if you had all those risk factors of having a heart attack in future. They then plotted out, this graph really says a similar thing, risk of acute MI associated with exposure to multiple risk factors. So it's a little bit similar but different. You've got the individual risk factors here, and they begin to add them onto each other from here. So you've got 3 risk factors, all 4, plus obesity, plus psychosocial stress, and then all the risk factors here. And these are the odds ratio, again, how many fold increase each time you had, if you had these factors, would your chance of having a myocardial infarction be. Smoking, so I said, was about 2.9-fold increase, diabetes on its own 2.4, hypertension 1.9-fold increase, but you put, and then cholesterol 3.3, but then you add all 3 factors together and it goes up to almost, well, it goes up to 13. 4 factors up to 42, 5 factors 68, and so on up to 333-fold increase if you have if you're unfortunate enough to have all those risk factors together. And they were able to work out what's called the population attributable fraction, which is essentially, if you were able to remove all those factors, what could you avoid? How much myocardial infarction could you avoid? And they picked perhaps the top 5 reversible ones: smoking, lipids, hypertension, diabetes, and obesity. If you took away all of those, you could actually avoid 80% of all the myocardial infarctions. So what I'm trying to say here is that cardiovascular disease is largely preventable. I'm not saying anything unusual, that is well known. Cardiovascular disease is preventable. And in this study, which I can pick loads of other ones, 80% could be avoided if we got on top of it. Another part of the paper was devoted to, I'll just touch briefly on this, that some of these risk factors were protective. So these were the protective ones. If you didn't smoke, if you ate fruit and veg, exercise, alcohol, if you avoided all of these, you could really reduce your chance of myocardial infarction. In other words, having a healthy lifestyle could effectively, if you avoid smoking, adopt a healthy lifestyle, you could reduce your risk by 75%. So that just reiterates my point about we can largely avoid this cardiovascular disease. So because cardiovascular disease is such a prominent problem in terms of its effect on the population, but it's also preventable, there is a huge opportunity for preventative health here, huge opportunity. And so the government, obviously, and other governments nationally and internationally reiterate this: prevention of cardiovascular disease in this country is a national health priority. So what are our preventative interventions? This is where I need your help. So rather than treating individual risk factors, which is perhaps what we used to do 20 years ago, you remember hypertension, treat that, high cholesterol, treat that. Actually now, for the past 10 or 15 years, really we need to look at the overall effect of multiple individual risk factors. And the reason for this is that combined together, they have a much greater effect than the algebraic sum of all of them put together. So in this case, 2 plus 2 does not equal 4. 2 plus 2 could equal 8. And this has been shown to, by having a general score of all your risk factors, it's a much more accurate predictor of your outcome over the next 5 years. And so this score that we can have can predict your chance of having a heart attack or stroke over the next, in the future. And just to show you an example of this is taken from a review in the article, a very good review in 2005, looking at the absolute risk of cardiovascular disease over 5 years in patients by their systolic blood pressure at specific levels of other risk factors. And I'm just going to go through that. So on this y-axis here, I can just make out, is the 5-year cardiovascular disease risk per 100 people. So basically what's your risk is, just says that's a measure of risk. And this here is, these are per risk, these are with different risk factors as you go along. And the reference point, say, for this little blue mark here is a 50-year-old woman who doesn't smoke, who is not diabetic, has no risk factors really, and her blood pressure is 110. This next bar along is if her same person, if her blood pressure, systolic blood pressure was 120. This one 130, 40, 50, all the way up to 180. And you can see as we increase this initially healthy person, we start off with a risk of 1% over the next 5 years, it goes up to 3%. Okay? Now if we then add in that she's also got a cholesterol of 7, so her cholesterol before was 4, total cholesterol, her risk goes up a bit more. But notice the gradient is not the same, it's a bit steeper. Now if we then add into this same person, so she's also, not only has she got a cholesterol of 7, she's now also a smoker, and you steadily increase her blood pressure, what happens next? The gradient gets steeper. And this really just demonstrates, and then if I make a good cholesterol, the HDL go down to 1, it gets even steeper, and so on and so forth as I add in the risk. But the main point I'm trying to say there is that you can see that this adding simple things together is not the same. You don't get, it's not the algebraic sum, it's actually an exponential increase in that person's risk the more factors you add in. And if I just go back to that slide I showed you earlier in the inter-heart study, yes, this looks like a straight line as I add the risks in, but does anyone notice anything odd about that? Is it really straight? Look at the y-axis. It's not a linear scale, is it? It's a doubling, 2, 4, 8, 16, 32, 64. So this actually, if I was to do this in the normal way, 1, 2, 3, 4, this would be an exponential curve. It would be a curve going upwards. Does that make sense? So all I'm trying to say here, I'm sorry if I'm labouring the point, that the risk, every time you add a risk factor, it doesn't just go up by a factor of 1, it may go up by a factor of 10. So what can we do about this? How do we measure the score? Well, we all know, I'm sure, the absolute cardiovascular disease risk score assessment as provided by the National Vascular Disease Prevention Alliance, which is a combination of Diabetes Australia, Kidney Health Australia, the Heart Foundation and the Stroke Foundation. And they all got together in 2012 and rejigged the guidelines, and they say that we should be doing this score for everybody over the age of 45. And everybody over the age of 35 if you're an Aboriginal or Torres Strait Islander origin without a history of cardiovascular disease. So we're talking about people who have got no vascular disease at all at the moment. So remember, 45 years or older, 35 if you're Aboriginal or Torres Strait Islander without cardiovascular disease. And they should get their cardiovascular disease risk score assessed and treated if necessary. And then we can give them we can calculate the likelihood of them having a heart attack or stroke or vascular disease in the next 5 years. And this is the calculator. I presume most of you know this. It's very simple. I use it in clinic. I was using it yesterday in clinic in the afternoon. You just have to key in. It's based on the Framingham risk equation. You just put in the gender, their age, systolic blood pressure, smoking status, total cholesterol, HDL cholesterol, whether they're diabetic or not, and if you have to hand their ECG, you don't have to, whether they've got left ventricular hypertrophy, and you just press go and you get a score. It's as easy as that. And the score that you usually get is low risk, less than 10% risk in 5 years, moderate risk 10 to 15%, so 1 in 10 chance of having a heart attack or stroke in the next 5 years, and high risk over 15%, the red area, 1 in 7 chance. You can communicate that reasonably well to the patients. In fact, I did yesterday. I'll just take you through an example. It's a female, as I say, 50, just like the one we talked about, 110 systolic blood pressure, no smoking, cholesterol of 4, good cholesterol, HDL is 1.6, diabetes, no. I don't know whether she's got LVH on her ECG or not, only 1%, right? And so I could turn the screen, turn the monitor to the patient and go, look, you're very low risk. Contrarily, I had the next patient came into my clinic yesterday, male, 55, 140 systolic, he hadn't had a heart attack, smoking status, yes, he continued to smoke, he cut down from 40 a day to 3, his cholesterol was 7.5 actually, HDL was 1, didn't have any of this, his heart attack stroke was 19%. I just turned the monitor and I said to him, you're doing all right, well done for cutting down your smokes, but your heart attack and stroke risk is 19%. That means you've got a 1 in 5 chance of having a heart attack or stroke in the next year. And the look on his face, he goes, right, I need to do something about this, what do I do? And I say, right, this is what you need to do, and we went on to that. So I think it's actually graphically quite useful to show it to them. So what do you do then when you have the score? So you've got the score, the patient's sitting there, you go through this relatively simple algorithm. If they're high risk, more than 15%, you commence 2 medications, an antihypertensive medication and a lipid lowering therapy. The antihypertensive medication can be one of the following, it doesn't matter which one, an ACE inhibitor or ARB, angiotensin receptor blocker, thiazide diuretic, or a calcium channel blocker like amlodipine. And a statin, you can pick them. I favour atorvastatin, rosuvastatin, or you can try simvastatin. And you give them those medications, and you tell them you've got lifestyle modification as well, you recommend that, and then you follow them up in 6 to 12 weeks to see whether their blood pressure's changed and see how they're going. Moderate risk, initially you just provide lifestyle advice and support, so lose weight, stop smoking, less salt intake and so on. And then you review them again in 6 months' time. And if their risk factors stay high, then you may consider adding in medication at that point, or if you've been successful, then you can continue with a lifestyle intervention. And low risk, you may or may not provide lifestyle advice, and you should review them every 2 years. There's a caveat to this, in that there are some people just automatically go into the high-risk category. And the automatic high-risk categories are those with diabetics over the age of 60 years, diabetes with microalbuminuria, moderate or severe kidney disease, so their glomerular filtration rate is below 45 mils per minute, very high cholesterol, so a total cholesterol of over 7.5, or familial hyperlipidemia, hypercholesterolemia, and very high blood pressure, which is a systolic of 180, or a diastolic over 110, and they automatically go into the high-risk category and should get a statin and antihypertensive medication automatically. So we've got this score, it's been around for quite a while now. What is the uptake of absolute cardiovascular disease risk scoring? Okay, so we thought, I mean I can quote lots of things, but in our hospital we decided to do a wellness survey on our 5,000 staff, and we screened loads of things, and this included, we thought, well, we'll just see how many have actually got their cardiovascular disease risk score checked. So we have about 5,000 staff. We've got a 20% response rate, which is pretty standard. Actually, it's quite good. Long questionnaire of 10 or 15 minutes, and out of those, 648 staff were eligible, so they were the age of 45 to 74 years, and they'd not had prior cardiovascular disease. And 93% had not had their cardiovascular disease risk checked, which is slightly surprising considering we're all health staff, we work in a hospital. But these figures are very similar to what's going out in the population actually. And so there was a very good study, so I'm going to go scientific now. This is a very good study, so we've done our little survey, but the facts are we weren't able to publish it because they were so bad, the results actually. Our chief executive was not keen. But nevertheless, I thought, well, I have to put a paper up here. So one by Emily Banks, who's head of population health at the National Centre for Epidemiology and Population Health in Canberra. And they published something in the Medical Journal of Australia 2 years ago entitled The Absolute Risk of Cardiovascular Disease Events and Blood Pressure and Lipid Lowering Therapy in Australia. So what they did was they took about 10,000 people from the Australian Health Measures Survey, and that basically is a survey across the nation. They selected a general population, so it's not a specific group. It's supposed to be representative of the Australian population. They do a survey and they have access again to the biometric measures. And they were able to, from this, calculate the absolute cardiovascular disease risk scores in these people who were just walking around in the community. And they were able to get their information on the medications they were taking. Specifically, they could also look at the antihypertensive and statin medications they're on. And as a result of that, they were then able to calculate or measure the proportions on guideline recommended therapy according to their risk. And then they were able to extrapolate this to the Australian population because the Australian Health Measures Survey is representative of the Australian population. And granted, there's a few obvious assumptions in that, but let's just run with it. So I've looked at gone a bit into the details, but the important thing is to get things in perspective. Out of the 4 million Australians there are in the country, 7.3 million are between the ages of 45 and 74 years of age. And surprisingly, or not surprisingly, 20% of these 7.3 million are high cardiovascular disease risk according to the data, and actually what we experience on a day-to-day basis, which you'll see as I talk. And of these 20% high-risk patients, 11% have no prior CVD, so that's 811,000, and 9% have got prior cardiovascular disease, so they've had a stroke or they've had a heart attack. So just think about that. That's 1.45 that's one in, so if you take a group of people with age 45 to 74, 1 in 5 of them in the room will be high risk. 1 in 10 of them will not know it because they've actually not had a heart attack or stroke yet. That's a lot, isn't it? It's most of my friends. So they then went on to look at the pharmacological treatment, and this is where it gets interesting. Pharmacological treatment of these patients. And on this side is the percentage or proportion. On the y-axis here, let's forget about this here for the moment. This is just primary CVD risk. In other words, they've never had a heart attack or stroke before. This colour means they're not taking any medications at all. So this group is high risk here, more than 15%. They should all be on a statin and antihypertensive. Nearly half were not on anything. And a third, 29%, were only on one medication. And only a quarter were actually on dual medication. So that's an enormous number of people that were not on the right medication. And of those with cardiovascular, established cardiovascular disease, again, 20% were not on anything. Isn't that bizarre? 35% taking one only. And we won't go into this, but I can just see that some people who've got very low risk are actually on medication. And there are studies to say that the whole scoring thing will not only recategorize, gets people who need to be on it on drugs, but they'll also get people who are on medications who should not be on medications off them. So if you break down the numbers, primary high CVD risk, in other words, not had a heart attack before, not got any vascular disease, on no medications, 382,000 people in the population are not on, who are high risk and not on any meds. Same thing, 233,000 are on just one medication, and if you've got previous CVD, there's 129,000 people out there not on any medications who've got established cardiac disease or cardiovascular disease, and 225,000 with prior cardiovascular disease who are just on one medication, which is a grand total of almost 1 million people, or 13% of the Australian population, aged 45 to 74, are at high risk, not currently receiving guideline recommended therapy. Now, if you then extrapolate that and go, well, how much is that? If they all had a heart attack, let's say they all had a heart attack or stroke, just bear with me. That works out at about $24 billion. If they all have one in the next 5 years, that's the cost for an acute admission. And if you look at the literature, by using, obviously not everybody's going to have a heart attack, it's about 1 in 10, 1 in 5. You could save about, if you use the preventative therapy, you could save about $7 billion over the next year. So why is there such a low uptake? There are lots of reasons. We conducted a survey, and we're not alone in this, the other countries have got the same issues. We conducted a survey last June to December on the Sunshine Coast. We asked 88 GPs what the barriers enablers were to cardiovascular disease risk scoring were. We have some preliminary data. So 96% of general practitioners were aware of the concept of cardiovascular disease risk assessment, which is good. 75% thought it was a valuable thing to do, cardiovascular disease risk assessment. Now 14% said they undertook it in all eligible patients. 64% said they did it in at least 6 patients out of 10 who were eligible. And 20% said they did it in less than 4. So it's not great. 68% used our own score system, the Australian CVD risk score, and 6% still believed that their own clinical judgment, that they knew the patient best, was the best thing. So that's over 1 in 20 as they go, I know what I'm doing, I'm going to ignore the score system. When we asked them what the barriers were, lack of incentives, so they didn't feel that there was any monetary incentive, or there's not enough time and so on to do that, so 1 in 4 felt that. They didn't believe that there was any effective lifestyle modification services that they could refer on to, which I think is true, if I'm honest. Lack of funding, so there's, they do send it to people, they're not sure that it will actually, they don't get suitably reimbursed for it. And about half felt, which I thought was quite a lot actually, felt that there was sufficient time, so they didn't think, so half of them thought they had enough time during an interview to actually go through it. I actually think that would be quite hard. You'd have to spend at least 5 or 6 minutes calculating the score and then going through what they need to do to change their lifestyle. What are the enablers? Patient education, 44% agrees. So the population themselves don't know anything about it, and that's true, borne out from our survey, which I talked about earlier. Computer prompted reminders, 58% felt that would be helpful if their own system would flag up that someone's high risk and they should do something about it, because I think a lot of people don't actually, they may have all these scores in there, but it's not joined up, if you like, and shown to the practitioner. Pre-screening by practice nurses they felt would be helpful. So 60% thought that practice nurses could do this quite effectively, and I'll be asking about your opinions on that later. And the recall of eligible patients. So there is a way of actually finding out who these patients are, because believe it or not, the data's in the system and they're remaining untreated, but there's no one, it's not being put together and they're not being recalled. So the conclusion from our study, and I haven't analysed all the data properly yet, but the majority of GPs are aware of the score system and they think it's valuable, but a significant proportion of patients are not being assessed, and scope to increase cardiovascular disease risk scoring within general practices does exist. They think better use of IT systems, pre-screening potentially by practice nurses, and education of the patient themselves. And when we asked our own staff why they're not having ACVD risk assessed, so again, of the 455 patients who responded, of whom I think eligible, 83% said I didn't know it existed, was not aware I needed one. 5% said they haven't had time. 4% said it wasn't relevant to them. And a couple of percent said they just didn't want to know. And so what interventions are underway to try and improve this? Well, there's lots. The one I know about is the My Health for Life, run by Queensland Health in conjunction with the Heart Foundation and Griffith University are doing it. It's about lifestyle interventions. I can refer, or GPs can refer to this, patients who are high risk or moderate risk, and they go into a program. It's a $27 million program. So there's a lot of money being spent on this. So now I want to talk about surveillance. So surveillance is important, and it's particularly important for a lot of diseases, either if they're serious or they're very common. And having a surveillance system in place is essential because it allows you to, across a population or region, is to allow us to quantify the magnitude of a disease, in this case cardiovascular disease risk. So how big is the problem? How small is it? We don't know. There's no measure at the moment. It's also useful, a surveillance system is also useful to document the distribution of cardiovascular disease risk geographically. In other words, where is it worst in our region? We may be doing really well in Maroochydore, but we may not be doing so well in wherever, Gympie, and therefore we can target our resources more effectively. It also allows us to monitor the effectiveness of our prevention strategies. So the Queensland Health My Health for Life programme, if we were if that's $27 million is being poured into the system, what measures have we got in place to show that what accurate measures have we got in place to show that the risk is decreasing and this expensive intervention is making an effect or not having an effect to allow us to modify it. It also allows us to, with information, because knowledge is power, we need this data to inform public health policy and planning. Otherwise we don't know what we're doing. Just pockets of information here and there, we're really not doing it in the right way. We need a comprehensive plan. And it allows us, a surveillance system should also allow us to identify untreated individuals at high risk who can benefit from treatment, as I've already talked about. So currently, no surveillance system for monitoring cardiovascular disease risk scoring exists within the Australian population. Now, as I said earlier, I have no conflicts of interest. I have no affiliation with PenCS. I'm just opportunistically looking at this. So PenCS, as you may or may know, how many people here are familiar with PenCS? Okay. PenCS is a health analytics software. It is present in most general practices and PHNs across the country. License the PHNs, and the PHNs offer it to general practices. And it's a national population health analysis and reporting tool in primary care. It is Australia's major provider of health analytics software, so 28 out of 31 PHNs in the country have licenses for its use. And it is able to provide monthly reporting on, it does provide monthly reporting on 15 million patients, 7,900 doctors, for 7,900 doctors and 5,600 general practices. And there's two products really, main products. The first one is the CAT4, which is a product of PenCS called Clinical Audit Tool, and it is present in each practice, and it allows you to extract healthcare data and provides feedback directly to the GP on the performance of that particular practice. So it might tell you how many diabetics have had their HbA1c checked, or how many smokers have been to stop smoking clinics. And it's compatible, this CAT4 is compatible with the majority of GP clinical information systems, and is able to calculate an ACVD risk score for you if you ask it to, provided you put the data in. PatCat, now I apologise for this, but I didn't name them, but PatCat is the other thing called practice aggregation tool, so you can get your tongue tied when you refer to all these, when you're talking about it to people. It is the second product of PenCS, and it is a tool that provides analysis of the population. So it's a web-based system that extracts de-identified data from CAT4, if you like, aggregates the data, and then is a reporting tool on population health analysis. So the more practices you have, you can take this de-identified data out and then look across regions or populations. And this can act as a population surveillance tool for cardiovascular disease risk. Now, PenCS claim on their website that they can be used for population health statistics, high-level views of patients, and those at risk for surveillance. That's what it says it can do. And this is an example of what you might see if you were asked it to do to look at cardiovascular disease risk. So, can you all see that? This graph here is a 5-year risk of a cardiovascular event in a GP practice. I think it's a GP practice, maybe just one practice, of 7,400 patients, and of those eligible for CVD risk checking, about half, or just under half, 2,800. And they had data on 1,300, so it was incomplete data. So you've got 1,300 patients with their cardiovascular disease risk score assessed. And these colours represent the risk. So red's high, green is low, and blue is moderate. and here is the number of patients on this axis, and these are the age ranges here. So if you look at this, as expected, the 45 to 49-year-olds, most of them are in the green low category range, and I think there's about 5 or 6 people in the yellow high risk range. Go to the 70 to 74, there's obviously a lot more people in the moderate and high risk categories. You've got 42 patients in the 15 to 19% category, and perhaps another 20 in the very high risk group. So this is what it can do for you. And there's a filtering tool then. You can apply it and say, well, how many are not on any medications at all, not on any cardiovascular, and it will spit out an answer. So out of those patients in the high risk category, you can actually see how many are not being treated. And so I've looked at the preliminary data for our region, a very quick look. We have 334,000 just on the Sunshine Coast, and if you include Wide Bay and various others, it goes up to 500,000. So 50% have of the 45 to 74-year-olds in the system have the score available. 18% are high risk, so that's again your 1 in 5, and 25% are not on any medication at all. And you look at that and you think, well, that's very odd, but that's what's coming out, and it's totally in agreement with the published data. And so I actually went to a practice, and this is one of the higher performing practices who has a high data, its data completion is relatively high. He has 3,800 patients in his practice. So I asked him, I said, well, can you just give me, just so I'm not imagining things here, what is the actual, how many of your patients really are on medications or not on medications? So primary high CVD risk, so no previous CVD, high risk though on the score, not on any medications. He had 77. So he's typed this, goes, oh yes, there's 77. Yeah, I said, you're not doing anything about it? He goes, not yet, no. This is just what's happening, this because we've actually asked him to do it. Then of course if you go for the automatic high risk group, do you remember I talked about the automatic high risk groups? So I said no meds and diabetes or microbiome use. We add up again 40, so we end up, and we couldn't filter unfortunately for hypercholesterol. There's nobody with familial hypercholesterolemia, but we couldn't, doesn't have a system for blood pressure and cholesterol yet. But we ended up with 125 patients in his practice that are high risk and not on any medications. So we're doing a study. So our study is, first objective is to evaluate PatCat, that's the population tool, to act as a surveillance system for monitoring absolute CVD risk in the population of the Sunshine Coast region. The second thing we're going to do is evaluate PatCat as a surveillance system for monitoring guideline recommended pharmacological treatment of patients who have high cardiovascular disease risk in the population of the Sunshine Coast region. And thirdly, we're going to undertake a pilot study to examine whether CAT4 can support the recall and then improvement of treatment of high-risk patients who are not on guideline-recommended therapies. We're just going to test it out. And you may say, well, how do you evaluate a surveillance system? Well, there's a standard set of guidelines that you stick to, provided by the Centre for Diseases Control in America. And there's a whole list of things you have to go through, stakeholder engagement, so that'd be like practice nurses, PHN, Heart Foundation, hospital, secondary care, and epidemiology. And you get together to make sure we're asking the right sort of questions. What do we want out of this particular surveillance system? Then we describe the surveillance system and what it can and can't do. Then we collect some data and test it, look at the sensitivity, specificity, positive and negative predictive values. And we focus the evaluation design. We make sure that we're actually doing the right thing in the time and resources that we have available. Gather all the evidence together, and then study outcomes. We provide a report at the end of it. And so that's how you evaluate a surveillance system. So we're going to evaluate with an unbiased view of what pence can or can't do. Does it say, can it do what it says on the tin? Can it do it effectively for us? Regarding the recall and treat, that's a bit simpler. It's a pilot study, single-arm trial. We're just going to try, because it's a pilot study, I'm just going to take those 60 patients from that practice and see what happens. They're not on therapy, recall them, see how many attend, how many are high risk when I retest them, because of course time may have moved on, and how many actually agree to treatment when I explain what needs to happen. And we'll produce a report on that. So obviously the future aims is if PatCat meets the requirements to be a surveillance system, then we could implement this on a much larger scale, perhaps across the region or beyond. Cat4, the pilot study works, then we do it in a number of general practices, do a cost effectiveness analysis. Does the amount of resources we have to put into it generate the savings that we hope it would? And the overall intention, of course, is why we're all here today, is the large-scale prevention of cardiovascular disease. I've just got, in the last 20 minutes, if you wouldn't mind, I'm going to talk about something I haven't talked, I didn't put up on the screen, and I'll just be interested again in your opinions on this. So we're also carrying out 2 projects, very long titles. We're working on shortening them. I'm going to say them anyway. It's the Primary and Secondary Care Data Linkage and Integration Project. That's project number 1. And the second one is the Routine Dynamic Consent for Rapid Clinical Trials Access Project. So there's 2 projects. Data Linkage Project, which we've shortened, and called the Ready Consent Project, which I'll go into it to do with clinical trials. And our partners are the Health Service that I work in, Healthcare Improvement Unit, the Clinical Excellence Division in Queensland Health, and the Sunshine Coast Primary Healthcare Network. Team, myself, Amanda King here, and Dr. Mia Harris, the Project Officer. And it's funded by the Clinical Excellence Division and also our PHN. And we're getting in-kind support, a lot of in-kind support actually from our hospital. So, background to this, I've been on this journey for quite a while now, 5 years. There are 2 holy grails in healthcare delivery. The first one, I think, is linkage of patients' data from primary care with its matched counterpart in secondary care. So in other words, if you can get the data in one place, we keep talking about integrated care, you can only truly deliver integrated care if you've got all the data and the information in one place so you can look at it. And by having all the data in one place, you can look at areas of inequality across the region and direct interventions. You can facilitate with this data health service planning. You can target interventions to those people most in need. Establish services with that data information to prevent avoidable hospital admissions, ED attendances. You can enable people to stay well in their community. Detect barriers to prevent there not being where best practice is not being undertaken, and also it's a rich resource for research. Yet, true data integration of primary and secondary care has yet to be realised, and the main obstacle to this is lack of patient consent. And the reason you need patient consent is because you need to take the identified data out of primary care in order to allow you to link it to the secondary care data. If you take out de-identified data, you don't know who to link it to, so you have to have identified data. And you can't take people's identified data out of a practice unless you have their consent. You need to get their individual consent, and that's what's been the stumbling block. People have tried geospatial mapping and so on and so on, never really worked. So that's an important point to remember. The second holy grail is translational research. We keep using that word, which is basically taking basic research, bench-side research that's been done in zebrafish and mouse and discovering something and then actually getting it into affecting the person on the street. Good example is we know that dieting, weight loss. We know that cardiovascular disease risk scoring, giving people drugs, gets them to reduce their risk. But getting it from that translation research is translating what we know in clinical trials and actually getting it to happen to the person so it makes a difference to our population. And that's always a problem. And clinical trials that assess new interventions, as I've mentioned, drugs and devices, underpin this objective. And clinical trial success is dependent upon having timely access, rapid access to patients in sufficient numbers and getting the right patients too. And research budgets, so if you have $2 million for a research program, $1 million may go on looking for the right patients. Research budgets are consumed searching for these patients. So access to a large data repository or shopping list of patients with all their particular disease states who have consented to be recontacted to discuss potential participation in clinical trials research would be an ideal way of overcoming that problem. So our aims in this study are, number one, by obtaining individual patient consent, we will assess the feasibility of transferring identifiable patient data out of the general practice into our hospital database, and then integrating and linking it with matched secondary care data. So we're going to take the identified data out with their permission and link it. We're going to perform meaningful analysis on the data to demonstrate its potential. And thirdly, by obtaining patient consent, again, dynamic consent we call it, in this case, we will assess the feasibility of using the database to identify patients suitable for recontact to discuss potential, and I use the word potential because they're not big force, we're just going to discuss whether they're interested, participation in clinical trials research. This is a concept diagram. My team said it looked, well, I think it looks like an insect, but I apologise to rush it up quickly, but simply to summarise it quite nicely. So you've got the GP data here, this half of the circle, hospital data over here, patient consent is central to everything. You combine it together to get the linked integrated data. And this provides, having the data in one place allows the information in one place is for effective service planning and delivery, promotes translational research, rapid access to large numbers of the correct patients for clinical trial participation, and it provides a model, a potential model for other health services to adopt. So our current status is we started on this last year. We have all the consents done. We've got ethic approval for both of these, so we thought that would be a hurdle, but actually it's gone relatively smoothly. We're just piloting it in 4 practices. We aim to approach 5,000 patients. 4 practices sign up, potentially another 2 in the offing. We have created the software, a widget that allows the healthcare staff in general practice to tick a yes or a no as to whether the patient's consented or not, and if they consent yes, it travels securely to the hospital database or on pre-established electrical networks. We've established the mode of secure transfer, the mode of messaging, so HL7 messaging, which is a robust and well-recognised form of transport. We have established our linkage methods. How do we link so the data all comes in, so you've got the name, the date of birth, the individual healthcare identifier, the whole lot. How do we then link it to the patient's data? It sounds simple, it isn't, because there are 5 health services in our hospitals in our region. Each time a patient goes to one of those, they get a new unique reference number. So we have to negotiate that pathway, which we've done. And we've done some preliminary testing of transfer of data from A to B, from B to C to D. But we've yet to do the whole thing in one go, which is what we're going to do in a few weeks' time. We're in the progress, we're making progress in terms of database creation. We have to establish GP contracts because we're paying practices for every patient they approach, $7. We have to send in some ethics amendments, so we're including children as well. We have to negotiate our research governance in our hospital. Obviously there's a risk here. And we have to do end-to-end testing, as I've stated. The future then, so what we're trying to do, this is a proof of concept study, which is different to a pilot. Proof of concept just to see whether we can actually do it, whether people sign it, whether we can transfer the information securely, whether we can perform some test searches and look at comparisons, just some simple things. Out of the 5,000 people we approach, we anticipate about 85% will say yes to the data, a significant less for clinical trials to be approached, and out of the 5,000 I expect, say 85%, that's about 4,200 people will say yes. So out of those, 10 to 14% will have had some contact with the hospital in the previous year. So you're looking at just 400 to 500 people will have in the database. Well, that's over 1 year. We're actually going back 10 years, so it'll probably be more than that. So if this is shown to be successful, then we will the next step is to try and get more of the coast, Sunshine Coast, to be signed up. So the idea is to get the whole of the Sunshine Coast signed up, do some real-world data analysis, engage clinical trials, perhaps produce a blueprint for other health services to use.